A very good morning to all. Can you please let me know if I'm audible and visible both? Please give me a thumbs up on the chat box. Yes. So, very good morning, Deepak. So, before I start with the MCQs, let me tell you something about the iconic subscription of Unacademy. So this iconic subscription of Unacademy is something that gives you three things. One is it gives you all the privileges of Unacademy Plus. Unacademy Plus is where you cover the entire syllabus coverage through live patches. There is updated recorded content and you learn from India's top educators. They are clinically oriented integrated sessions and there is a question bank with 75% case-based questions. Also, there is access to PYQs, live tests and quizzes. In addition to this, you also get notes which are very concise, revisable notes and they are based on the recorded content of the plus classes. And they have been added with visual aids, images, flowcharts and tables. With this, you also get a mentoring session which is by the Unacademy educators where you are told about the preparation strategies, education experiences and peer success stories. So for all this, what you need to do is to subscribe to Unacademy iconic subscription, and for that the minimum cost currently is only 24,700 rupees for 6 months. For this you need to subscribe, and for subscription please use the code MENTOR, MENTOR will be the code for you to have this offer price where you have this additional 5% off. Okay, you can see the costing. For 36 months, it's hardly 45,600 rupees. Okay. Then going on to another offer where you pay less and get more. So if you buy the iconic subscription for 9 months, you get 2 months free. So 9 plus 2 months offer is available at a price of just 26,600. So here, as I told you, you have access to Unacademy Plus. You also get the notes, which is a hard copy note, and you also have mentoring sessions. And this particular offer is valid only till 23rd of July. And to subscribe to this, please use the code MENTOR. MENTOR is the code which you need to use. Okay. Now, let's begin with the MCQs. I want you to be very active, involved. You can ask me questions. If you do not understand anything, if you have something unrelated also is completely fine. Now, let's go to the first question. A child presented with itchy plaques over the neck, bilateral popliteal and the cubital fossae. The picture is provided to you. What could be the diagnosis? Is it atopic dermatitis, dermatitis herpetiformis, pemphigus vegetans or psoriasis? So I see Indu Gopal answering A. Anyone else? Deepak? Shagufta? Yes, Deepak. Deepak also says A. Right, so Indu and Deepak, both of you are right. The correct answer for this question is atopic dermatitis. The reason why it is atopic dermatitis is because you can see that the typical presentation is in the form of eczematous eruptions which are involving the flexures in a child. And they have also mentioned that there are similar lesions over the neck and the popliteal fossae. Right? So this is fitting into the clinical description of atopic dermatitis. Dermatitis herpetiformis is a vesiculobullous disorder which is associated with gluten sensitive enteropathy in most of the cases, and this eruptive lesions, they are extremely pruritic. Okay, and the classical sites of lesions are usually on the extensors of the knees and the elbows. Okay, So basically here there is cubital and popliteal foci involved. So obviously the answer is not dermatitis herpetiformis. Pemphigus vegetans is a variant of pemphigus where you have lesions which involve the flexures, but they are vegetative lesions. So you have growths, cauliflower like growths occurring in the flexures. So again this does not fit. Psoriasis usually occurs on the extensor aspects of the knees and the elbows, and the classical presentation is in the form of erythematous indurated plaques which are associated with silvery micaceous scales, right? So it's not psoriasis. So now let's go a little deeper into atopic dermatitis. Now what you need to know about atopic dermatitis is that itching is a very classical hallmark of atopic dermatitis, and the itch often precedes the rash. So it's called as it is the disease where the itch that rashes rather than the rash that itches. Okay. So remember, the hallmark of atopic dermatitis is the itch. Okay. And it is characterized by the itch, scratch, itch cycle. Okay. So you have a very low threshold for itch. You get the sensation of itch. If you scratch it, the itch perpetuates itself and then it keeps continuing. In addition to this, there are certain vascular changes where you have the periorbital, perioral and perinasal pallor, which is called as the headlight sign. So this can come to you as an MCQ. Please remember, headlight sign is seen in atopic dermatitis. And you also have something called as white dermographism. So again, please remember, this is a very important MCQ. White dermographism is seen in atopic dermatitis. So basically, what is white dermographism? When you are going to scratch the skin, okay, you will see that there will be blanching. Okay, that's an abnormal vascular response. So you see blanching and that area turns a little pale. Okay, so that is something that one can see in atopic dermatitis. The triggers of atopic dermatitis are winter, woolen clothes, dust mites, stress and food allergens. Basically, the problem in atopic dermatitis is that there is a defective barrier function. So, when you have a barrier means that whatever is inside will remain inside and the things which are outside will not affect the skin. Now, when you have a deranged barrier, what happens is there is transepidermal water loss. Means the water from within the skin goes out into the environment and things which are outside can easily enter into the skin. Right? Now, there are three stages of atopic dermatitis. You have the infantile stage, which is varying between 2 months to 2 years. Then you have the childhood phase, which is between 2 to 10 years. And then you have the adolescent or the adult stage, which is more on the flexures. Any eczema can have three stages rather. Acute stage where there is active oozing and therefore wet compresses help. Then comes the subacute stage where you have oozing plus crusting, where you would benefit with creams, and chronic stage where the skin becomes lichenified. What is lichenification? Lichenification is where you have three components. One, there is hyperpigmentation. Two, there is induration. And three, there is accentuation of the skin markings. Okay, so there is chronic stage which is typified by lichenification, and in this stage you would prefer to use an ointment because of its occlusive property. So this is the infantile stage of atopic dermatitis where you can see that there are eczematous lesions which are occurring on the face. Here also you see the involvement of the face and there will be involvement of the extensors. So here you can very well notice the involvement of the extensors. So remember, in the infantile phase you have involvement of the face and involvement of the extensors. Right? Then comes the childhood phase of atopic dermatitis where you have involvement of the folds. Okay, so you have involvement of the flexures. That includes the cubital foci, the popliteal foci and the neck in most of the cases. Then after you have the adult phase or adolescent phase of atopic dermatitis where you have flexural lichenification. There can be associated hand-feet involvement as well. Now, what you need to understand here is that atopic dermatitis, it's a clinical diagnosis. Atopic dermatitis cannot be diagnosed by a patch test. Atopic dermatitis is not diagnosed via a serum IgE level. It is a clinical diagnosis. Okay. A very good morning, Dani. So what you need to understand here is that to aid our clinical diagnosis, they have put up certain criteria which are called as Hanifin-Raika's criteria. So according to the Hanifin-Raika criteria, there are major criteria and minor criteria. For a diagnosis of atopic dermatitis, you need all the major criteria and at least 3 minor criteria. Okay. Now first let's go to the major criteria. First is pruritus. Pruritus of course has to be there because as I told you, itch is the hallmark of atopic dermatitis. Second, there has to be a typical distribution. Like in the infant, you will expect the lesions occurring on the face and the extensors. In the adults and in the childhood phase, you would expect the lesions occurring on the flexures. And it has to be a chronic relapsing dermatitis. It should not be a one-off event that it came and it then went away and never came back. It is a chronic relapsing dermatitis and there has to be a personal or a family history of atopic disease. Right? So these are the major criteria. Then going on to the minor criteria, you should have at least 3 minor criteria. One is the Denny-Morgan fold. So what is the Denny-Morgan fold? It is a transverse linear crease which is seen under the lower eyelid. There can be ichthyosis. There is hyperlinearity of the palms and soles. Keratosis pilaris. Elevated serum IgE levels. Cutaneous infections more commonly because of Staphylococcus aureus. Why? Because Staphylococcus aureus is there abundantly in the environment and it can easily enter into the skin because of the impaired barrier. So there are very high chances of secondary bacterial infections which perpetuate the lesions of atopic dermatitis and also are pro-inflammatory. Further, herpes simplex virus can easily enter into the skin and can cause dissemination. So that is called as eczema herpeticum, also called as Kaposi's varicella eruption. Okay, so when you have any dermatological condition where there is an impaired barrier and the herpes virus enters into the skin and causes dissemination through the skin to the systems, then you would qualify it as Kaposi's varicella eruption or eczema herpeticum. So this is not only seen with atopic dermatitis, you can also see it with pemphigus foliaceus, you can also see it with scabies, okay, you can also see it with Hailey-Hailey and Darius disease, right? Next, in atopic dermatitis, you can have hand and foot eczema, nipple eczema, dry lips, skylitis, xerosis, and there can be eye changes like keratoconus, anterior subcapsular cataract. There can be white dermographism and Hertogase sign. Okay, what is Hertogase sign? Remember, Hertogase sign is the thinning of the lateral eyebrows. Okay, and there is pityriasis alba and eyelid eczema. Now let's see a few images. This is palmoplantar hyperlinearity. That means there is accentuation of the creases over the palms and there are more creases than what are expected on the palms. There is ichthyosis, which is extremely dry skin which becomes scaly and there are fish-like scales. Okay. Then this is white dermographism where you can appreciate the blanching out here. This is hand and foot eczema which can occur as a part of minor criterion of atopic dermatitis. This is pityriasis alba. Pityriasis alba, you can see it's a ill-defined hypopigmented minimally scaly patch occurring in a patient who is atopic, and this child will have these lesions on and off. Then you have keratosis pilaris. Keratosis pilaris is where you have the antenna sign positive. Basically here you see that there are follicular papules which are a little gives you a sandpaper kind of a feel when you feel it. Now let's go to the next question. All ready? Now the below given image is characteristically seen in which type of leprosy? Do you see it in borderline tuberculoid leprosy, lepromatous leprosy, borderline leprosy or histioid leprosy? Look at the image that is shown and you need to tell me characteristically in which type of leprosy do you see it? Anyone? Indu, Raja, Lovely, Deepak, Dani. So Dani says it's A. He says it's borderline tuberculoid leprosy. Hi Rahul, good morning. Can you please answer the question? Anyone, even if you are incorrect is fine. We are here to learn. So Rahul says it's A, Indu says it's A, Deepak says it's C, Ankit says it's A. Okay, so the correct answer here is it's borderline leprosy. Why am I saying it's borderline leprosy? Because if you see the lesion, you can see it's having an inverted saucer shape appearance where the inner border is well defined and the outer border is sloping. Right, so this fits into the clinical description of borderline leprosy. Okay, so in mid borderline leprosy, you have many lesions, but they are still countable. So you will have up to 10 to 30 lesions. There are many thickened nerves. The lesions, they start crossing the midline. There are two borders visible. So you have an inner border and you have an outer border. The inner border is well defined and the outer border is ill defined and is sloping. That's because the immunity of the body is giving up, right? It's going down. So that is why it is allowing the bacilli to spread. So that is why the outer border is ill defined. And this appearance is called as the inverted saucer appearance. It's also called as the Swiss cheese punched out or dimorphic appearance or annular lesions. Now, in mid borderline leprosy, the sensations, they gradually start improving and the sweating improves. Please remember that mid borderline leprosy, it's the most unstable form. Okay, so please remember mid borderline leprosy is the most unstable form of leprosy. Okay. Now, let's go to the next question. You have a child who presents to you with itchy lesions on the scalp with hair loss as shown in the image. What would be the next step? Will you do a KOH mount, slit skin mount, gram staining or a biopsy? Anyone? Humble doctor says A. Dani says D. Deepak says A. Indu says A. Right, so majority of you are right. The correct answer here is a KOH mount. Yes, Brinda also says, Lovely also says A. Right, so the correct answer here is a KOH mount, and what we are dealing with here is nothing but tinea capitis. Here we are dealing with a non-inflammatory variant of tinea capitis. Okay, so if we have to read about tinea capitis, please remember that this particular entity is more common in the children versus an adult. That's because in children there is less sebum, right? And why? Because sebum is something that comes into play post puberty under the influence of the androgens, right? So sebum is fungistatic. Okay, so that is why you do not see tinea capitis very commonly in adults versus in children, right? So this is a disease that you see more commonly in children, and it can be classified as ectothrix or endothrix. Ectothrix means the fungal elements and the spores, they are situated outside the hair shaft, and endothrix means the fungal elements and the spores, they are situated inside the hair shaft. There are two variants, clinical variants of tinea capitis. You have the inflammatory variant, which can be Carryon or Favus, and you have the non-inflammatory variant, which can be grey patch and black dot. Okay, now first let's go to black dot variant of tinea capitis. The black dot variant of tinea capitis is caused by Trichophyton tonsurans and Trichophyton violaceum. It's an endothrix infection. Okay, now remember the mnemonic TV. TV is always inside the house, correct? So T stands for tonsurans and V stands for violaceum. So remember that in endothrix infections, Trichophyton tonsurans and violaceum, what do? They tend to kind of weaken the hair shaft. So when the fungal elements and spores are situated inside the hair shaft as a part of the endothrix infection, they weaken the hair shaft. And when the hair shaft becomes weak, what happens? It breaks off at the surface of the scalp, and that is seen as black dots, right? So the broken hair at the surface of the scalp, they are seen as black dots. So this is nothing but black dot tinea capitis, and it does not fluoresce under the Woods lamp examination is because the lesions, the fungal elements are inside the hair shaft. So this is what a black dot variant of tinea capitis looks like. You can see that there are multiple alopecia patches, and the patches of alopecia, they are covered with black dots. This is a magnified view where you can see the black dots much better, and these black dots are nothing but the hair which are broken off at the surface of the scalp. Now the grey patch variant of tinea capitis is caused by the ectothrix organisms. Ectothrix organisms means the fungal elements and the spores are situated outside the hair shaft. So remember the mnemonic cats and dogs fight. Where do the cats and dogs fight? They will fight outside the house, right? So ectothrix means out. And cats and dogs fight stands for Microsporum canis, Odoni and Ferruginum. This particular infection is going to fluoresce under the Wood's lamp, and that is going to give rise to a greenish fluorescence. Okay, so this is the grey patch variant of tinea capitis, and this is the greenish fluorescence that you see on Wood's lamp examination. Now let's go to Carryon, which is the inflammatory variant of tinea capitis. Carryon can be both ectothrix or endothrix. Remember the mnemonic, men can be very red. Red stands for inflammation. Okay, so men can be very red is the mnemonic for you to remember the organisms that cause Carryon. So that includes Trichophyton mentagrophytes, Trichophyton verrucosum, Microsporum canis. Okay, men mentagrophytes, can canis, V very verrucosum. Okay, so Trichophyton mentagrophytes, verrucosum and canis can cause Carryon. The classical presentation of Carryon is a painful inflammatory boggy swelling on the scalp with pus and sinus formation. This is something that you need to remember, and this is a very classical description. Sometimes they may not give you an image and just give you the description. So please remember this: painful inflammatory boggy swelling with pus and sinus formation. Because it's an inflammatory condition, you also have associated lymphadenopathy, which is posterior auricular or post-cervical lymphadenopathy. And then you have Favus, which is an endothrix infection, which is an inflammatory variant of tinea capitis. And this is an infection which is characterized by air spaces within the hair shaft. It is caused by the organism Trichophyton schondleni. So clinically you see it's a concave yellow-shaped crust which is called as the scutula. There is fungus inside the hair and it forms air spaces. Okay. So remember, Favus caused by Trichophyton schondleni. It is the only Trichophyton species which is going to fluoresce under a Wood's lamp, and it is characterized by the presence of scutula. And within the hair shaft you will find air spaces. These are the 4 points that you need to remember about Favus. Now, treatment of tinea capitis. Treatment of tinea capitis, you can give, ideally see, you can isolate which particular species is causing the tinea and then accordingly start the medication. If it is Microsporum species, Griseofulvin works better. If it is Trichophyton species, Terbinafine works better. But in case if they have not given you any options, they have not mentioned which particular species is causing it, then you have to mark Griseofulvin. Okay. Now, let's go to the next question. The most specific and typical sign of juvenile dermatomyositis in a 17-year-old patient is photosensitive skin rash, nail bed capillary changes, Gottron's papules and a malar rash. Let me know what you think. Please put it on the chat box. Right, so I see Brinda, Deepak, Lovely, Humble, Indu. All of you have answered C. Dani says A, and Travel with Chandan and Nirmala says it is B. Okay, so here we are talking about a case of dermatomyositis, right? Photosensitive skin rash is more suggestive of the malar rash of lupus erythematosus, so that is incorrect. Malar rash is also given to you as a no, malar rash is incorrect because malar rash is what you expect in systemic lupus erythematosus. Okay, all these three things can be seen in dermatomyositis. You can have a photosensitive skin rash, you can have nail bed capillary changes in the form of dilatation of the blood vessels of the nail bed, and you can have Gottron's papules, which are flat top lichenoid papules that we see on the distal and the distal interphalangeal and the proximal interphalangeal joints, as well as on the proximal on the metacarpophalangeal joints. Okay, so the correct answer here though is the Gottron's papules. So what you need to remember about dermatomyositis is that it is a autoimmune disorder which is predominantly affecting the skin and the proximal skeletal muscle. So it is called as myo for muscle, and itis means inflammation. The classical cutaneous signs are the heliotrope rash. It is an erythema with purplish tinge on the upper eyelid, which is pathognomic. Eyelid rash with eyelid edema often correlates with the muscle disease activity. Okay, so please remember, heliotrope rash is an erythema with purplish tinge. Heliotrope rash is called so because the color of the vivacious erythema that is present on the eyelid is mimicking the color of the heliotrope flower. Okay, so heliotrope rash is an erythema with a purplish tinge on the upper eyelid, which is pathognomic. Eyelid rash with eyelid edema often correlates with muscle disease activity. Then you have the shawl sign, which is a fixed macular erythema on the V of the chest across the shoulders and the outer arms in the shawl distribution. And you also have the Gottron's papules, which are inflammatory flat top lichenoid papules on the PIP, DIP and the MCP joints, which are pathognomic for the condition. So here you can appreciate the periorbital vivacious erythema, which the color of which is mimicking the color of the heliotrope flower. So it's a purplish vivacious erythema, and you can see it is associated with edema, and this edema is something that is correlating with the involvement of the muscle. Here you can see the flat topped vivacious papules on the metacarpophalangeal, proximal and the distal interphalangeal joints, and they also have nail fold changes where you see dilated capillary loops, right? So on the nail fold you can see periungual erythema, dilated capillary folds or the loops in the proximal nail fold, and damaged cuticle. Gottron's sign is different from Gottron's papules. Gottron's papules is just where you have a lichenoid macule. You don't have a papule. It's not elevated. It's flat. On the PIP, DIP and the MCP joints, you can have mechanics hands, which are rough hyperkeratotic palmar surface in patients with anti-synthetase syndrome. And on investigations, this has come in the exams. So please remember, Gottron's papules, heliotrope rash and shawl sign. They are associated with anti-MI2 antibodies, while the mechanics hands myositis and interstitial lung disease, they are associated with anti-Jo1 antibodies. Okay, so Gottron's papules, heliotrope rash, shawl sign, anti-MI2, mechanics hands, myositis, interstitial lung disease with anti-Jo1 antibodies. Okay, now let's go to the next question. You have a young girl who presents with leukotrichia and the lesions as shown in the image. What is the most likely diagnosis? Is it focal vitiligo, segmental vitiligo, piebaldism or nevus depigmentosis? Let me know what you think. Please mention it in the chat box. Nirmala says it's C. Anyone else? Dani says it's A. Aisha says, is it B? Deepak says it's B. Indu says it's B. Humble Doctor says it's D. Ankit says it's B. Yes, so most of you are right. The correct answer here is segmental vitiligo. Okay, segmental vitiligo is vitiligo. Why? It is occurring in a depigment. They are depigmented macules and they are in a segmental fashion. So it is segmental vitiligo. Focal vitiligo will not follow any particular pattern. There may be just few discrete lesions. And piebaldism is a condition where you will first have these depigmented lesions occurring at birth. The lesions will be associated with a white forelock. So you have an approximate diamond shaped area of depigmentation on the forehead, and you also have white hair over it, and you have multiple depigmented macules on the body. And these multiple depigmented macules, classically they are going to have areas of normal pigmentation within them. Okay, so that is what you see in piebaldism, which is not the answer here. Nevus depigmentosis also occurs at birth. Nevus depigmentosis has typically these serrated margins. Okay, and a nevus depigmentosis may have associated leukotrichia, but the dermoscopic examination will show the presence of retained pigment versus absence of pigment in patients with vitiligo. Okay, so the correct answer here is segmental vitiligo. So if you see the pathogenesis of vitiligo, there are multiple theories. You have the neurogenic theory. So the neurogenic theory says that segmental vitiligo is seen along the dermatome because there is a neural toxin which is released at the nerve endings, and that is destroying the melanocytes. Then there is an autoimmune theory which says that there is autoimmune destruction of the melanocyte, and the antigen is the melanocyte by itself, and that is why there is damage to it. It has a strong genetic predisposition. There are depigmented milky white patches of leukotrichia, particularly in the areas of repeated friction and pressure points like the dorsi of the hands, fingers, feet, elbows and ankles. If you see the classification of vitiligo, it can be divided as localized or generalized. Local vitiligo can be divided as focal, where there are single or few macules in one anatomical area. So this is focal vitiligo, where it is present only in one anatomical area. Then you have segmental, where you have linear presentation in a segment. Then you have mucosal vitiligo, where it's involving majorly the lips and the genitals. And lip tip vitiligo is where there is involvement of the lips and the fingertips. So these are the localized variety of vitiligo. Then you have the generalized variety where you have acrofacial involvement. So in addition to the acral areas, you also have involvement of the face. Then symmetric generalized vitiligo, which is called as vitiligo vulgaris, which is the most common presentation, where you can see there are multiple depigmented lesions and they are bilaterally symmetrically distributed. And then you have vitiligo universalis, when almost the entire skin has turned white and there are only a few islands of normal skin remaining. You should know that vitiligo can be associated with other autoimmune conditions like autoimmune thyroid dysfunction, diabetes, pernicious anemia, Addison's disease, SLE, rheumatoid arthritis, autoimmune polyendocrine syndrome and alopecia areata. Yes, Dani, segmental, you will see it in a segmental fashion. So you may see it in a linear fashion. Then there is trichrome vitiligo. So basically, if there is an intermediate hypopigmentation between the normal skin and the depigmentation, there will be three colors, right? There will be a normal skin, there will be the hypopigmented skin, and then the depigmented skin. So this is called as trichrome vitiligo, and the Keepness phenomenon is positive in this case. What is Keepness phenomenon? Anyone? Keepness phenomenon is the appearance of lesions at the sites of trauma. That trauma can be anything. It can be mechanical, thermal, chemical, any kind of trauma. You will see the lesions appearing at that site. Okay. So Keepness phenomenon is positive. Now, diagnosis of vitiligo is a clinical diagnosis. The diagnosis can be aided by a Woods lamp, which will show the presence of bluish white kind of fluorescence, and dermoscopy and a histopathology. On histopathology, you will see there will be absence of melanocytes and hence absent melanin. So how do you treat vitiligo? If there is less than 20% of the body surface area involved, you can use potent steroids. You can use calcineurin inhibitors like tacrolimus, calcipotriol, topical PUVA and excimer laser. When you have more than 20% of the body surface area involved, you can use narrowband UAB therapy, which is very safe and effective. If the vitiligo is rapidly spreading, okay, it's unstable vitiligo. In that case, you may want to limit the spread of the vitiligo by giving systemic steroids. In some cases, if it is indicated, You can give azathioprine, you can give newer drugs like tofacitinib, okay, and systemic PUVA can also be given. Now, when the lesions are very stable, when the lesions are not increasing in size, when new lesions are not appearing, then the surgical option for stable vitiligo is skin grafting, which is a full thickness graft. You can use a autologous melanocyte skin cell transfer. You can also use a split thickness graft or suction blister grafting. In certain cases of universal vitiligo, where there are a few islands of normal skin remaining and the rest of the skin has become depigmented, it is better to depigment the remaining normal skin by applying melanocyte destroyer creams like monobenzyl ether of hydroquinone so as to achieve a cosmetically better outcome. Phototherapy in vitiligo acts by removing the Langerhans cells and removing the autoimmune lymphocytes and stimulating the melanin synthesis. So this is something helpful to stabilize vitiligo as well as to repigment vitiligo. Either a UVA or UVB can be given, and UVA therapy does not needs photosensitization prior with Sorelin. So you ask the patient to consume Sorelin. 2 hours after the consumption of Sorelin, you expose the skin to UVA therapy. UVB therapy does not need photosensitization. There are certain poor prognostic factors to vitiligo which you should be aware of. If it's a very young onset, extensive disease, vitiligo which is present on the bony prominences, leukotrichia on the non-hairy areas, and lip tip vitiligo. These are poor prognostic factors because when you want to repigment a patch of vitiligo, the pigment can come from the surrounding normal skin or it can come from the hair. If the hair is depigmented, it becomes a poor prognostic factor. If vitiligo happens on areas like the bony prominences where there are no hair, again it becomes a poor prognostic factor. And underlying thyroid disease is also one of the conditions which can give rise to vitiligo. Can be giving rise to a poor prognosis of vitiligo. Now, you should also be aware of an entity which can mimic vitiligo, and that is called as contact leukoderma or chemical leukoderma. So, say a patient is wearing a watch, okay, and that belt of the watch is containing leather wallets, watch straps that is containing something called as monobenzyl ether of hydroquinone. Or if the patient is wearing a bindi, okay, and this bindi has an adhesive behind it, right? And this adhesive is containing something called as para-tertiary butyl phenol, right? So both these chemicals, they can cause chemical leukoderma by being toxic to the existing melanocyte. So it physically destroys the melanocytes, and that gives rise to depigmentation at the site of application, right? So histologically there is going to be an absence of melanocytes. So histologically it will be identical to vitiligo, but the mechanism by which the melanocytes get damaged is different. In vitiligo it's an autoimmune damage to the to the melanocytes, while in contact leukoderma it is toxic exposure to that particular chemical. Now, identify the finding associated with the condition as shown in the image. Is it the isomorphic phenomenon? Is it the Meyerson's phenomenon? Is it the Gottrin's papule or the Nikolsky sign? Anyone? Dani, Indu, Shobhi, Raja, Humble Doctor, Lovely Mahi, Ayesha Hussain, Ankit, Travel with Chandan, Brinda, Akash says it's A. Nirmala Paras, Deepak Raja says A. Aisha says isomorphic. Yes, all of you are right. Indu also says A. So this is nothing but the isomorphic phenomenon of Keebner. As I mentioned, that Keebnerization is something that happens because of the isomorphic lesions appearing at the sites of trauma. Okay. So with that, I would like you to know a little more about Keebnerization. So remember that Keebners can be true Keebners. True Keebnerization is what you see in psoriasis. You see it in vitiligo, and true Keebnerization is also seen in lichen planus. Then you have pseudo Keebnerization. Pseudo Keebnerization is seen in Pseudokeepnerization is something that you will see in auto-inoculable conditions like molluscum contagiosum and warts. Okay. Then you have reverse keepnerization. Reverse keepner means that the lesions will disappear at the site of trauma. Okay. So reverse keepnerization is something that you may see in some cases of vitiligo. Then there is remote reverse keepnerization. Remote reverse keepnerization means when you traumatize the area, that lesion will disappear, but even the distant lesions will disappear. So that is seen with granuloma annulare. Okay. Then you have rare causes of Keepnerization. So among the rare causes of Keepner, you have conditions like vasculitis, you have Haley-Haley disease, Kaposi's sarcoma, lichen nitidis, lichen sclerosis, okay, erythema multiforme. Right, so these are the causes, rare causes of Keepnerization. Okay. Meyerson's phenomenon, Aisha, is seen in molluscum contagiosum, where you have an eczematous appearance of the skin surrounding a molluscum contagiosum. Okay, and that generally suggests that the body has identified the virus, okay, and is mounting an immune response against it. Okay, Gottron's papule, I already told you, it is seen in dermatomyositis, and Nikolsky sign is something that you would expect in multiple conditions which are having an intraepidermal blistering. Okay, so Nikolsky sign is something that you would see in Nikolsky sign is something that you would see in conditions like pemphigus, Haley-Haley disease, in staphylococcal scarlet skin syndrome. So Nikolsky sign says that when you apply tangential or shearing force onto surrounding normal skin on a blister, okay, not on the blister by itself, but on the surrounding normal looking skin on the blister, you will see that there will be peeling out of the skin. Okay, so that is called as the Nikolsky sign. No, Mehul, this will not be very useful for people who are in BAMS. This is specifically for people who are appearing for their NEET PG, FMGE, INI-CET examinations. Okay. This is an MCQ based lecture and I am discussing currently images and questions that should be known before you appear, before you go in for your FMGE examination. Okay, Mehul? Right. Now let's go to the next question. Identify the findings shown in the image below. Is it herpes labialis, herpangina, molluscum contagiosum or impetigo? Everybody is very confident this is A. Very easy, right? So this is, what are you seeing on the picture? You are seeing that there are multiple vesicles. They are in a grouped fashion and these vesicles are present over an erythematous edematous base. So this is nothing but herpes labialis, which is caused by herpes simplex virus. Herpes simplex virus 1 more commonly causes herpes labialis than herpes simplex virus 2. Herpangina would occur more commonly in the throat rather than on the lips, and molluscum contagiosum typically presents as a pearly white umbilicated papule, right? So it does not present with vesicles and hence it is incorrect. Impetigo typically presents with uh, transient vesicular lesions which form pustules and then they rupture, giving rise to erosions, and these erosions they tend to be covered with honey colored crusts. Okay, so that is what we see in impetigo. So what exactly happens in the herpes simplex virus infection is, see, once you get a herpes labialis or you get herpes genitalis, this particular virus always remains inside your body, okay? And it remains latent in the sensory ganglia after the uh, primary episode of herpes, okay? and then it periodically reactivates. So Ayesha is asking me, can you give a short classification of the types and causes of HSV? Okay. So basically, see, if you see herpes, see, the HSV comes under the family of human herpes viruses. Okay, Aisha. So human herpes viruses, they have different classes. So you have the HHV1, which is nothing but the herpes simplex virus 1. And this herpes simplex virus 1 causes herpes labialis. Then you have HHV2, which is herpes simplex virus 2, which causes herpes genitalis. Then you have herpes simplex, you have the human herpes virus 3, that is HHV3, which is nothing but the varicella zoster virus. The varicella zoster virus causes herpes zoster and also causes varicella, right? Then you have the HHV4, which is nothing but the, can anyone tell me what is HHV4? Anyone? Human herpes virus 4 causes CMV. CMV causes colitis in HIV positive individuals. Okay, and it also causes, it can also cause in neonatal infections, right? So then HHV5 is EBV, which is causing infectious mononucleosis. EBV is also implicated in oral hairy leukoplakia, right? Then you have HHV6. HHV6 is implicated as one of the viruses causing, it is implicated as one of the viruses causing what? HHV6 causes pityriasis rosea. HHV7 is also implicated in pityriasis rosea. HHV8 is associated with Kaposi sarcoma. Correct? Yes. HHV6 also causes roseola infantum. Yes, very good. Roseola infantum or exanthum subitum. The other name for roseola infantum is exanthum subitum, and it is caused by HHV6. Yes, yes, Deepak, Kaposi sarcoma is caused by HHV8. Okay, and Dani, parvovirus B19 causes erythema infectiosum. Okay, also giving rise to a slap cheek appearance, right? So Dani, it is parvovirus B19. It's not a herpes virus, though. But please remember that erythema infectiosum is caused by parvovirus B19. Right. Now what happens is that when this herpes simplex virus comes into contact with the skin, it enters into the keratinocytes. When it enters into the keratinocyte, it causes the ballooning degeneration of the keratinocytes. Okay, so the cells, they tend to get ballooned up, and then what happens is that these balloon cells, they tend to come together and the intercellular walls are lost. So that gives rise to the presence of a multinucleated giant cell. Okay, so what you have is ballooning degeneration and reticulate degeneration giving rise to multinucleated giant cells. So basically, when you take a Zank smear from a lesion of herpes, you will see that there will be the presence of multinucleated giant cells. Paras Patel is asking me about the leprosy classification. So Paras, here you need to read up the Ridley-Joplin classification of leprosy, and there is an Indian classification as well. But the Ridley-Joplin classification is what we use more commonly when we have to classify leprosy. So according to the Ridley-Joplin classification, you have leprosy clinically into tuberculoid leprosy. Then you have borderline tuberculoid, mid-borderline, borderline lepromatous, and lepromatous leprosy. Now see, as you go from tuberculoid pole to the lepromatous pole, you will start seeing that the number of lesions increase, the number of nerves that are involved increases. Tuberculoid leprosy, the lesions are completely anesthetic, okay, with greatly thickened nerves. They are completely anhydrotic, means there is no sweat that happens, and they are completely dry. Sometimes there can be loss of hair on that patch as well. So that is what you appreciate in TT. But as you go down towards LL, you will start seeing that the the sensation gradually improves, and you also start seeing that the lesions, they tend to become more symmetrical. The nerve involvement also tends to become more symmetrical. Histopathologically, you will see that the granulomas, the tubercular granulomas, they tend to be replaced by the macrophage granulomas. Okay. So gradually, as you go down, you will see that the lesions, they tend to become more infiltrative. They tend to become, the skin appears more shiny, the sweat comes back, and in the lepromatous leprosy, you will see diffuse infiltration of the skin with appearance of papules and nodules, and you also have associated facial involvement in the form of leonine facies. There is involvement of the earlobe, where you see thickening of the earlobe, infiltration of the earlobe, and you will also get involvement of the palms and of the dorsa of the hands and the feet, which become swollen with associated epistaxis. Right, so that was about the classification of leprosy, Paras. So this is what herpes orolabialis would look like, and the treatment of this condition is with oral acyclovir. When you have recurrent episodes of herpes genitalis or herpes labialis, when you have more than 6 to 12 episodes per year, a continuous antiviral prophylaxis is recommended. And for patients who are resistant to acyclovir, you can offer them foscarnet or cidofovir. So we have the last few minutes remaining for this session. If you want me to discuss anything specifically, please let me know in the chat box. Till then, I'll go to the next question. Which of the following drugs is used as a nail lacquer and belongs to the morpholines? Is it amrolfene, oxyconazole, cyclopyroxolamine, or tioconazole? Indoacyclovir, for the primary episode of herpes labialis, you need to give 400 milligram 3 times in a day with plenty of oral fluids for 7 days. While you are treating a secondary episode of herpes, you will need to give tablet acyclovir 400 milligram 3 times in a day with plenty of oral fluids for 5 days. Okay. Okay. The correct answer here is amrolfene. Amrolfene belongs to the morpholine group and it is available as a nail lacquer. Okay. So Paras, Nirmala, Ankit, Aisha, please take note. The correct answer here is amrolfene. Let's go to the next question. Look at the image that's shown to you and identify the drug that is used to treat the condition. So first make a diagnosis by looking at the lesion, and you have to tell me the answer. Will you give him antifungal, anti-tubercular, topical steroid or anti-leprosy therapy? Nirmala says it's psoriasis. Who else? Anyone would want to answer? I think it's not visible because I'm coming in between. Let me just move a little. I hope you can see me. See the lesions now properly. Or what I can do is I can just shift this. Okay, I hope now you can see it better. So basically, see what you see in this lesion is you are seeing that the plaque is extending at one end and it is getting better at the other end. Can you appreciate the scarring out here? See, this is the scarred area. Okay, and this is the progressing end. So basically, this is nothing but lupus vulgaris. Okay, it's not leprosy, it's lupus vulgaris. See, this kind of scarring is not what you expect in leprosy. This kind of scarring is what you expect in lupus vulgaris, and the buttock is a very common site of lupus vulgaris. Okay, so this is lupus vulgaris, and the treatment you would give for lupus vulgaris, because it is a kind of cutaneous tuberculosis, you will want to treat it with anti-tubercular therapy. Okay, I hope that's clear. So lupus vulgaris occurs because of inoculation of the bacilli into the skin of a patient who is already sensitized, and hence the MON2 test is moderately positive. It can be exogenous or hematogenous. Usually there is a single plaque of grouped round papules which heals at one end and it progresses at the other end. So this is something very, very classical. It heals at one end and it progresses at the other end, and therefore it heals with scarring. So when you have an annular plaque associated with central scarring, the answer will be lupus vulgaris. When you have an annular plaque associated with central crusting, it will be leishmaniasis. And when you have an annular plaque with itching and scaling, it will be tinea. Okay. Apple jelly nodules are seen on diascopy of lupus vulgaris. Matchstick test is where a wooden matchstick, when pressed on the lesion of lupus vulgaris, the stick will penetrate the thin dermis easily but stands on itself without support on the firm dermal nodules. And skin biopsy will be suggestive of tuberculoid granulomas. So Dani is asking me any cheat codes to remember drugs in dermatology topics. So there are multiple cheat codes, Dani. It will be impossible for me to cover this right now in the next 2 minutes. What you can do is you can go through the Unacademy lectures. There are recorded sessions of almost 18 hours where I have covered entire dermatology, and there are a lot of images, lot of MCQ discussion as well as mnemonics that are provided for you to easily remember. So please do subscribe to Unacademy. It is definitely a worthwhile exercise with the discounted rates that are available. And definitely please use the code MENTOR. MENTOR is the code which you need to use to subscribe to Unacademy. Med Psycho has asked me the psoriasis types. So types of psoriasis, see, there are psoriasis. You have psoriasis, which is the most common variant of psoriasis, which is psoriasis vulgaris. Then you can have flexural psoriasis depending upon the area of involvement. So you can have flexural psoriasis, which involves the folds. You can have palmoplantar psoriasis, which involves the palms and the soles. You can have scalp psoriasis, which affects the scalp. Okay. Further, depending upon the inflammatory nature, you can have pustular psoriasis. Pustular psoriasis by itself can be divided into the localized acrodermatitis continua of Halepi and the generalized variant, which is the von Sombusch variant of pustular psoriasis and the annular variant of pustular psoriasis. Further, you can have involvement of the nails. You can have involvement of the joints in psoriasis. So you can have psoriatic arthritis, and psoriatic arthritis by itself can be divided as the oligoarticular form. Then you have the pauci-articular form. You have the rheumatoid arthritis like psoriatic arthritis. You have the ankylosing spondylitis type of psoriatic arthritis. Okay, and you also have arthritis, which is classical arthritis, which is psoriatic arthritis, which is involving the distal interphalangeal joint. Okay, fine. So that was about the classification of psoriasis. Okay, so we have finished our 1 hour of this session. Thank you very much, everyone. You all have been very, very interactive and very responsive. All the best for your upcoming examinations, and do not forget to subscribe to Unacademy, and please use the code MENTOR, MENTOR, for that discount. Okay, so see you very soon. Thank you very much. Bye.